Acute appendicitis. Acute appendicitis is mainly a condition of young adults, but it affects all ages, although uncommon under 3 years. Despite its declining incidence, it is the commonest surgical emergency, and special care has to be taken with the very young and the very old. The symptoms can vary because of the different positions of the appendix. It is basically a clinical diagnosis. Clinical features. Typical clinical features are, usually under 30 years of age. Initial pain is central abdominal, sometimes colicky, increasing severity and then continuous shifts and localizes to RIF within 6 hours. May be aggravated by walking, causing a limp, or coughing. Sudden anorexia, nausea and vomiting a few hours after the pain starts, plus or minus diarrhea and constipation. DXT localized RIF pain plus A.N.V plus guarding right pointing arrow. Acute appendicitis. Signs. Patient looks unwell, flushed at first, then pale, furred tongue and halitosis, may be febrile, low-grade fever. Tenderness in RIF, usually at McBurney point. Local rigidity and rebound tenderness. Guarding plus or minus superficial hyperesthesia. Plus or minus psoas sign, pain on resisted flexion of right leg, on hip extension or on elevating right leg due to irritation of PSOs, especially with retrocecal appendix. Plus or minus obturator sign, pain on the examiner flexing patient's right thigh at the hip with the knee bent and then internally rotating the hip due to irritation of internal obturator muscle. Rovsing sign, rebound tenderness in RIF while palpating in LIF. PR, anterior tenderness to right, especially if pelvic appendix or pelvic peritonitis. Variations and cautions. Abscess formation, right pointing arrow, localized mass and tenderness. Retrocecal appendix, pain and rigidity less and may be no rebound tenderness. Loin tenderness, positive PSOs test. Pelvic appendix, no abdominal rigidity, urinary frequency, diarrhea and tenesmus, very tender PR, obturator tests usually positive. Elderly patients, pain often minimal and eventually manifests as peritonitis, can simulate intestinal obstruction. Pregnancy occurs mainly during second trimester, pain is higher and more lateral, harder to diagnose, peritonitis more common. Perforation more likely in those who are very young, elderly or have diabetes. Investigations. Investigations, including imaging, are of limited value. Blood cell count shows a leukocytosis 75% with a left shift urea and electrolytes, to assess hydration prior to surgery. CRP, elevated. Ultrasound shows a thickened appendix 86% sensitivity, 81% specificity, affected by gas shadow. Plain X-ray may show local distension, blurred PSOs, shadow and fluid level in caecum. CORT scan 94% sensitivity, 98% specificity also allows other causes, especially in the female pelvis, to be evaluated. Laparoscopy beta HCG. Management. Immediate referral for surgical removal, the gold standard. If perforated, cover with sfotaxime and metronidazole. If abscess, radiologic drainage, antibiotics plus or minus interval appendicectomy. It is reasonable to offer a conservative approach for uncomplicated, low-grade cases, with careful monitoring and antibiotics in selected patients. One detailed study showed that surgery was the safest option.